Let's talk a little bit about, okay, you've chosen an agent for the second line setting. You're following their scans and obviously their clinical status and their comorbidities. Clinical trials, we use RCC progression to take them off of this treatment. We have this phenomenon called pseudo-progression that's reported, at least to a certain extent, in the melanoma literature about how IOs work in cancer. What's your decision making about stopping therapy, continuing through progression, and not moving on to the next line of therapy until sufficient proof that in fact the current line of therapy is not benefiting the patient?
So Bob, let's speak specifically about nivolumab. What I do is I will re-image every 8 weeks, which is a little different. Some people re-image every 12, but I'm doing this in part because I want to see whether or not there's pseudoprogression so that we actually have information. I won't act on progression on nivolumab after 8 weeks unless the patient is dramatically symptomatically deteriorating. And actually it's really interesting to see individuals on nivolumab where you get radiographic progression, but then you see normalization of laboratory parameters. Their anemia goes away. Their mild liver dysfunction goes away. They feel better. Their albumin increases. They're clearly, their body is improving overall. And then you repeat images 8 weeks later and you may start seeing shrinkage in those people. I'll give a person who has progression and feels relatively well on nivolumab another set of scans 8 weeks later. And if they're progressed in that second set of scans, I'll move them on to a different agent.
So let me just interrupt for a second. Would you say that with the IOs, you have a more likelihood of defaulting to watching a bit before switching than you might have with a targeted agent?
So that was my temptation, and that's what I started doing. And there were presentations at ASCO last year about treatment beyond progression. Now I've had some experiences, these are anecdotes, but oncologists sometimes live by these, where I've been lulled into a sense of security with agents on these IO agents, where then all of a sudden 6 months later we have sudden progression in an idiosyncratic manner. So I'm a little less comfortable just keeping a person on an IO agent with mild, slow progression because I've seen these idiosyncratic changes either in bone or in brain. So I will actually move people on to another agent after 6 months for sure if I see this inexorable progression systemically. And again, this is not something that's been validated with level 1 data, but it's what I feel comfortable with.
So Michael, practical stuff. I mean, we have our, one of the nice things is as I travel around the country, I'm impressed by how often people watch what we say. They're often, we see in our clinic a lot of kidney cancer patients every week. Doctors in the community don't. And what they tend to do, which I was surprised at, is if I have a patient that I'm planning to see this week with kidney cancer, I'll go on to Onc Live. I'll see what the group says about how I should be thinking about it, and then I'll modify my approach based upon the information and the literature that I read. So help the community doctor who's faced with the infrequent kidney cancer patient to know, how to structure their thinking around decision making.
I think this is a real confusion that I'm seeing from some of my referrals. Before these drugs, nivolumab and cabozantinib, were approved, I was primarily seeing mainly first-line patients and then very refractory patients. But now I'm getting calls and getting referred these patients. Essentially, it's second line. And what should we do? Should we do nivo? Should we do cabo? Sometimes also, as Eric said, because of this story of pseudo-progression, maybe after the first scan of nivolumab, what do we do? I agree with Eric before this last ASCO with the story from the FDA and Dr. Scudier's group about pseudoprogression, I was probably lulled into a false sense of complacency, just saying, on whatever the first scan is, I'm going to give them a little more time. I'm not doing that as much because I have been, again, anecdotally been kind of burned by being complacent like that. So I guess to circle back and give a kind of a practical recommendation, In that patient who's treated in the first line with a VEGF receptor TKI, treated in the second line with nivolumab, at their first scan, if they do have pretty clear progression, I'm switching them at that point. And again, anecdotally, but one thing I have seen is what appears to be kind of what I'm referring to as a tailwind effect. This is a little provocative, but a tailwind effect, meaning when I give nivolumab, whatever I give next seems to work a little bit better. And I can only, speculate why that is. There was data presented at ASCO about patients, who had lived 3 years or more, even with the best response of progression on nivolumab, seemed to have a benefit. Now, limitations to that data.
Well, but I think we've all experienced that, and I think that's going to be an interesting paradigm when we start to think about how to generate next generation data. In terms of when we think about targeted agents, we kind of lump them, but maybe prior IO therapy may set the patient up to be somewhat different.